Thursday, May 8th. This is House Healthcare. And we are turning our attention to S53 again. And we have in with us Alex McCracken from DIVA. That's you. I didn't recognize you.
Good morning, Madam Chair.
Yeah, and very much this year.
It has been a little while.
See you.
It's great to be here, Madam Chair, and it is great to see everyone. I have missed you guys this session. It's good to be back with you, and I'm happy to go into that testimony for this morning. For the record, my name is Alex McCracken. I'm the Director of Communications and Legislative Affairs for the Department of Vermont Health Access, and today I'm here to speak on S53. Madam Chair, representatives, thank you for the opportunity to testify today on behalf of the department. While DIVA agrees with the intent of this bill, the department is not able to recommend coverage of doula services at this time. DIVA has three primary concerns about the way S53 is written and its implications for the department's budget and processes. The first is lack of funding for DIVA. S53 does not contain an appropriation for DIVA, which would be needed to reimburse newly added doula services and supports. With anticipated costs being approximately $1.2 million gross annually, Vermont Medicaid cannot support an unfunded mandate with a significant fiscal impact. A new benefit with no additional funding would require a reduction of other Medicaid services. The second is programmatic lifts for DIVA. Adding doulas as a new covered benefit would require changes to the Medicaid Management Information System, or MMIS, to allow providers to be enrolled in Vermont Medicaid and be eligible to bill for services. These changes are significant and require time, resources, and prioritization. MMIS changes can take over a year to implement and require significant financial and administrative resources. The process for proposing MMIS changes and having those changes approved is arduous, and it requires the use of limited resources. Vermont Medicaid has limited capacity in the MMIS queue, and the addition of new provider types, provider specialties, and service codes needed for doulas will have to follow other required changes, making the implementation timeline proposed of 7/1/26 very difficult. Additionally, Vermont Medicaid coverage of doula services would require a state plan amendment, or SPA. State plan amendments are formal processes by which the Agency of Human Services requests approval from the Centers for Medicaid and Medicare and Medicaid Services, CMS, for any changes, additions, or removals of services or providers under the Vermont Medicaid program. DIVA has determined that a state plan amendment would be necessary for Vermont Medicaid to be able to reimburse for doula services. The SPA process opens up the Vermont Medicaid state plan for federal scrutiny, and DIVA would highly encourage caution in any attempts to obtain a state plan amendment, given the current volatility and uncertainty in the federal environment. Lastly, coverage of doula services would require a healthcare administrative rule to establish these services. Administrative rules typically take up to 18 months to be developed and implemented and require significant work and coordination within the department. Again, the currently proposed 7/1/26 deadline for Vermont Medicaid is problematic considering all of these programmatic considerations. The last thing I'd talk about is the voluntary certification process. DIVA has lingering concerns that OPR's voluntary certification process, as outlined in the Sunrise study, will be insufficient to meet federal requirements for reimbursement. DIVA must meet the minimum federal requirements related to education and licensure of enrolled providers. At this time, it is unclear if OPR certification will meet those minimum federal requirements. DIVA is happy to work with OPR and with providers to discuss this certification further, but Medicaid is bound within the limitations and requirements of the federal government. If ultimately DIVA requires more providers than OPR requires more of providers than OPR requires for state certification, this will have significant implications for the workforce available to DIVA. DIVA acknowledges the potentially significant benefits of providing Medicaid reimbursement for doula services in Vermont. However, S53, as currently written, poses significant financial challenges to the department and results in a large financial and administrative lift. Although we agree with the intent of this bill and we appreciate the potential positives in health outcomes and cost savings, the department is not able to recommend coverage of doula services at this time. Thank you, Madam Chair, members of the committee. I'm happy to answer any questions that I can.
Can you send your, can you send your testimony,
Yes,
written testimony?
absolutely can.
Didn't keep up.
No, I didn't keep up.
So before we get to other questions, I looked over all the testimony that Department of Vermont Health Access provided to the Senate. As this was going through the Senate, I believe it went through committees on health and welfare, committee on finance, as well as committee of appropriations. And I'm looking at your written, I'm sorry.
And GovOps.
And GovOps. Okay, for 4 committees. I'm looking at all of your testimony, written testimony, and none of these concerns were brought up in the Senate.
We raised these 3 concerns in our testimony with Senate Health and Welfare, and I'm happy to go back and look through for the written testimony. We certainly did raise the funding concern and the OPR certification concern, as well as the SPA. I think a couple of the administrative issues that I pointed out are new for this testimony, but all the rest of it is the same from the Senate.
I certainly understand that there is reluctance to seek coverage under our 1115 waiver. I guess I'm just wondering how much of your concerns, where would you rate that as in your level of concerns?
Rate it against.
Well, you've mentioned several things that you're concerned about, and I'm wondering the scrutiny on our 1115 waiver, how that ranks with all of your concerns. Is that the least of your concerns, your top concern?
I think it ranks pretty highly. I think whenever we approach the federal government for a SPA, we are open to federal scrutiny. And given the current context, that presents more unknowns, it presents greater risks, and it presents potential issues down the line with our interactions and our 1115 waiver with the federal government, or with the, sorry, not the 1115 waiver, they're separate.
Brian?
Does the 1115 waiver cover other reproductive health care services currently that are legal in Vermont?
I'm sorry, can you repeat the question, Representative?
Does the 1115 waiver currently cover other reproductive health care services that are legal in Vermont?
I would need to check with our policy team whether that's 1115 waiver or state plan amendment.
Okay. I'm just curious because you mentioned federal scrutiny, and I think that this is a reproductive health care matter. And so I wonder if it might draw scrutiny to other reproductive health care. And that's why I asked that. And I wondered if that might be why you're concerned.
I think that there's a standing level of caution that we want to use when we approach CMS in the current climate. We do cover most reproductive services and healthcare through either a state plan amendment or a waiver. It is mostly through state plan amendments. I think that the concern is that we don't know what the outcome may be from further scrutiny. And there's a lot of tools in the toolbox that could make life uncomfortable for Vermont Medicaid.
Ari?
Would you be able to provide language that what language would DVA think meet the voluntary certification process requirements? If it's not voluntary certification, then it's mandatory certification. Is there something more you think the federal requirements are asking for?
I think that's a conversation that we'd be happy to have with OPR. I think that when we're looking at federal requirements, it would probably be a lot easier to get that through with the stricter certification levels versus voluntary certification. We have to meet certain standards of education, experience, background, credentialing. That is something that we'd be happy to continue that conversation with OPR, but we don't feel that the current proposal in the Sunrise Initiative may not be entirely sufficient.
So there isn't a list of standards you could share with us?
I don't think it's quite as simple as that, but I'd be happy to check in with our policy team and see if there is a checklist or a list of requirements that we can easily provide. I think it's also, again, about holding up to scrutiny from the federal government.
I hear that. Yeah, I'm just asking specifically about the standards.
But yeah, we would need to connect with OPR on that one.
We recently passed S18, which I just realized got sent to the governor this week. So, yesterday. Okay, he finds that S18, which was freestanding birth centers. So that bill would have required that DIVA seek coverage for freestanding birth centers to be able to pay in that type of facility. Would have also meant that because we did a licensure piece around freestanding birth centers, that would mean that DIVA would have to go through the same enrollment processes and the same creating of, and I'm just curious, none of these concerns that you're bringing to us today held for freestanding birth centers, so why all of a sudden, like, why doulas now?
I hear your question, Madam Chair, and it's a good question, and thank you for bringing it up. I will say that we did testify in support of S18, the freestanding birth center bill, but within that testimony, we did caveat a word of caution around state plan amendments. I think that's a standard of concern with anything you approach CMS with in the current environment. I do think that the difference may also be in the replicability or the scale of birth centers across the country is very, very common. So there's less trepidation or less concern with approaching CMS with that request. Doulas are quite common, but not quite as common as birth centers for Medicaid coverage. And excuse me, and the issue also being that with birth centers, we enroll providers, not facilities. So it is easier for us to expand coverage for services that we already provide, labor and delivery, perinatal care, and allow that to happen within the setting of a birth center with providers that are already enrolled through Vermont Medicaid. To enroll a new class of provider, that's a different conversation with CMS for the state plan amendment. So not all spas are equal. This one presents some slightly more complicated features.
Well, in order to, I mean, yes, you already certify, say, certified nurse midwives. So you wouldn't have to do that piece, but if a freestanding birth center, you would have to pay a facility fee for that birth center, which would mean that you would have to enroll that facility. So there would be the same process of setting up a new enrollment mechanism, because currently you don't have a process for enrolling a birth center.
I'm not sure I understand, because if a Medicaid enrolled provider bills Medicaid, then that's the provider doing the service and being reimbursed for it. The setting isn't necessarily.
So there are two charges for delivery in a freestanding birth center. You have the professional component, which would be the professional who's delivering. And then there would also be a facility fee, which, I mean, because we took a lot of testimony on that, dramatically different from a hospital facility fee. And
Right.
I mean, you would have to enroll the facility. That's not the professional.
Right, and we enroll facilities all the time. That's a thing that we do, but we pay the facility, but we're also paying for services from qualified providers, from providers that are already certified or are already enrolled in Medicaid. We creating a whole subsection of provider, new section of providers, especially within the Sunrise Report's proposed voluntary certification process, would present greater issues than the birthing centers.
You mentioned that you recognize that there actually could be potential savings. Has there been any research done by DIVA on potential savings for the services for births attended by and perinatal care,
So we have,
sort of a doula as without have?
as part of the Act 97 work that we engaged in last year, we did do some investigation into potential cost savings around the use of doulas. I'm not prepared to testify on that right at this moment, but I do think that that is included in the annual report pages that detail the reporting requirements from DIVA. Happy to provide a copy of those for the committee.
Have the concerns around the enrollment piece?
And I'm sorry, I want to clarify that we did not conduct independent research. We did a review of some existing research, and that is what we have.
Okay. Have the concerns around the appropriation that DIVA feels would be required to stand up a new enrollment category of providers, was that brought up in the Senate? Because our fiscal note from our joint fiscal office yesterday did not indicate that that had been a concern.
It is a concern that we voiced in the Senate. The fiscal note that you received has an estimate of, I believe, $420,000 for the reimbursement for doula services. That comes from the very low end of our spectrum that we did in our analysis through Act 97. As Nolan mentioned in testimony yesterday, it all depends on utilization. And so we really don't have a great way to measure exactly what that utilization is going to be. But our estimates put it around from 10 to 30%. If it hits that 30% margin, it's 1.2 million. So that's the range that we're looking at as far as a cost impact for reimbursing doula services. And realistically, we're currently in an environment where it's very hard to expect that we will have a lot of cash flow for Medicaid to work with additional reimbursement for providers.
No, I understand that, and I realize that it will have a fiscal impact in the future for the program, for the services. Our joint fiscal did give us those numbers. That's understood. I'm more wondering about you spoke in your testimony about the resources and technical things that would be required in order to even set this up.
Will be the resources required for the programmatic lift?
Yes, and that was not in our joint fiscal note. So I'm wondering if that was brought up in the Senate at all.
I don't believe that we provided a number. I know that it would require resources that we don't currently have an appropriation for in this bill. So we would be trying to do what we can with the resources we have, which requires a level of prioritization that may impact other priorities and programs.
Any other questions for Alex? I'm sorry, I've been dominating the conversation. Curiosity.
Grateful you have.
All right, well, thank you.
Thank you, Madam Chair, members of the committee. I appreciate being in. And I'm happy to answer any more questions anytime.
Thank you. And you sent your materials.
They will be sent very shortly.
So we were unable to, Office of Professional Regulation is in the Senate until 10 o'clock. So we're gonna go off of